we're here at the Eagle Eye Laser and Surgery Center in Meridian, Idaho, and in their operating rooms. We're going to show you how we can use basically a relatively dated, older type Omeda ventilator from an anesthesia machine to ventilate a patient with COVID with ARDS. Understand when we ventilate patients with COVID, we're learning that the early phases, when it's a viral pneumonia, may not require anywhere near as much PEEP, and maybe we'd be able to use larger tidal volumes for those patients. As they evolve into an ARDS situation, then we're dealing with an ARDSNet style ventilation. And that's what we're going to be talking about here in this presentation. The anesthesia machine is very different from a conventional ICU ventilator in that it's a low flow ventilator. Most of the tidal volume delivery bellows are powered by gas, and that's usually oxygen. You would have to go in manually and switch it over to air if you had problems with O2 availability at the institution that you're working at. You really should take all of the vaporizers off. These are the vaporizers that take the liquid anesthetic gas, or liquid anesthetic, and turn it into gaseous phase to deliver to the patient. You take those off. You can, under some extreme circumstances, when you don't have sedatives available, and under the guidance of anesthesia professionals, use that to deliver sedation, but it is not recommended, as there's a lot of hemodynamic effects associated with the use of vaporized anesthetic that novices to anesthesia care might have difficulty dealing with and could be problematic. The ventilator itself, other big difference is going to be how we determine the FiO2. It's done by flows, and again, we're talking relatively low flows. We're only using 2 liters here. The way anesthesia machines are able to do that is hidden down underneath here. You can see this granular material here is soda lime. It's a CO2 absorber, so that the exhaled gases go through there, and the soda lime picks up the carbon dioxide and washes the carbon dioxide. And so we're able to run in a much smaller closed circuit. Anesthesia machines also have the capability for scavenging. That's not required as long as you're not using the vaporizer and you use an expiratory filter, which Clay is going to tell you about. Then we don't need to scavenge the gases that are exhaled. Other than that, most of the modern anesthesia ventilators have the capability. This one doesn't. It's an older one, but they have the capability to sense. So you can have triggered ventilation, have the ability to switch from pressure to control to volume control, and most of them can sustain PEEPs up to 20. Some of the newer ones can even go much higher than that, and can pretty much provide full service care for the COVID ARDS type patient. One important point I want to make is that what we're going to be talking about today is consistent with the Anesthesia Patient Safety Foundation and ASA guidelines for using an anesthesia machine for ventilation in the setting of the COVID crisis. This is really a measure in crisis care where the availability of ventilators are a problem, and anesthesia ventilators and anesthesia machines should be utilized by anesthesia professionals. So we really need to make sure that we have experienced, licensed, credentialed anesthesia providers that are managing the ventilators at the bedside. And the anesthesia ventilator is much more prone to obstruction, to valves that stick, to humidification accumulating within the system, and by virtue of that requires much more frequent checks than standard conventional all-purpose ICU ventilator. So frequent rounding and checking on the machine is really essential.
Okay, Clay's going to talk about setting up the Omeda anesthesia machine to be able to ventilate one of our COVID-19 patients.
So to begin with, it's just a standard anesthesia machine check that you would do before you used it for every single patient. Check the bellows, make sure that there's no leak. You are not going to have the sevoflurane on there. You're going to have an HME filter connected to the endotracheal tube, and you're going to have a standard Paul filter, which is used quite commonly, connected to the expiratory flow. For the COVID-19 patient with ARDS, we're going to discuss tidal volume control. We tend to use 4 to 7 milliliters per kilo with a rate of 20 to 30. We do an I&E of 1 to 2, 1 to 2.5. And you want to have a pressure limit max of 40, preferably 25 I think, down 25 to 30. You want to watch your minute volume, your tidal volume. Everyone knows how to manage your FiO2, the combination of using your oxygen and your air. And what you want to do as well is you want to watch for your plateau pressure. And you can do that on this old Omeda machine by setting your inspiratory pause, turn it on to about, say, 10%. You don't need to do this continually, but you do want to make sure that your plateau pressure is less than 25. In-tidal CO2, of course, is monitored. The lung machine, we're not generating in-tidal CO2, but that would read up here on your monitor. And as always, you have your soda line that you have to be aware of. You might have to change that out more frequently if you're ventilating somebody 24 hours a day. So you make sure that your pressure, your plateau pressure is lower, and then you can go back to your volume control. And it's just constantly monitoring the patient, like that's what we do. So currently we're in volume control mode, and if you are having problems with your plateau pressures and your max pressures, you can switch over to pressure control mode. And peak inspiratory pressure, say about 20. And then set that. And what you want to be aware of is obviously always watch your in-tidal CO2, your exhalation volume, and your minute volume, and see how you can generate those and keep in a lower pressure.